All right, I got the green light.
So I want to welcome everyone. Good morning, good afternoon, good evening, depending on where you are. Welcome to the Global Critical Care Fellow Seminar Series. It comes on every week around this time. And it's being done in collaboration with St. Paul's Hospital, Millennium Medical College in Ethiopia, Kolebu Teaching Hospital from Ghana, and Johns Hopkins University. So today, we have the pleasure of having Dr. Bhavna Seth with us, and she is going to deliver the lecture. Dr. Seth is an assistant professor of medicine at the University of Pittsburgh and the director of the Global Health Track in the Division of Pulmonary and Critical Care Medicine. She received her medical degree from Lady Hardinge Medical College, New Delhi, in a century-old institution where she served a socioeconomically underprivileged population. She was part of the medical education pathway during her residency in internal medicine at Boston University Medical Center, working in inner city Boston with a diverse safety net population. Subsequently, she completed her Master of Health Sciences at Johns Hopkins Bloomberg School of Public Health, with her Pulmonary and Critical Care Fellowship at Johns Hopkins. Bhavna has lived and worked in several resource variable settings across India, the United States, Vietnam, Ethiopia, and Botswana, the latter for 6 months during her Global Health Fellowship with Beth Israel Deaconess Medical Center, Harvard. She's interested in understanding how health systems can be strengthened across the Global South to deliver high-quality care in resource variable or denied communities. So we will welcome her. She's going to talk about the approach to common endocrine emergencies in the ICU, a very, very crucial topic. During the presentation, I'll ask that those who have joined would mute their microphones. You can type anything you want in the chat, a hello, a hi. If it's a question, we'll address it after the presentation. All right, so we'll have 45 minutes for the presentation, and then we will have a discussion, answer questions for the 30 minutes afterwards. So a warm welcome to Dr. Seth. The floor is yours.
Thank you, Esther. Thank you for the lovely introduction. And I'm really excited to be here, and I'm even more excited for this topic. If I wasn't in a critical care doctor, I would have probably been an endocrinologist, and I absolutely loved endocrine in my training years, mainly because it's something, there's very few things in medicine that we can fix, and endocrine issues are something we can fix. It's usually a titration issue. Either your hormones are too high or too low, and there are ways that we can fix them. And endocrine emergencies are my favorite type of ICU syndrome because they're very, if caught, they're very amenable to quick resolution and getting your patients better. And so it's still one of the reasons I actually got interested in critical care was actually diabetic ketoacidosis, because following a very simple rhythm and algorithm and approach, patients who come very, very sick in about 24 hours can get better and leave your ICU. And I found that very magical. So just, this is a very broad topic, so we won't be able to cover every hormone and every element and nuance related to them, but I'll make sure that we touch the key high touch points. And so we hope to be able to, the main issue with endocrine emergencies is being able to recognize them and when to think about them. And they're very hard because they can manifest within other diagnoses or look like other diagnoses. So they often masquerade as other elements. So why is this important? Is because, just as mentioned, they're easy to miss. So someone who's in shock could have shock from sepsis, but could have shock from an endocrine emergency, or could have both. And so they can occur concomitantly with a trigger, especially when you're in a stress state. Your hormonal balance may not be able to compensate for that stress and manifest more and need additional support. Um, and also, it's important because many times your patients may have not had a prior endocrine diagnosis. So you may not know that they have diabetes, or you may not know that they have a thyroid illness, but their very first manifestation may be in this acute emergency situation. And if you're able to get them through that emergency situation, say they have DKA and you get them better, then you can plug them in to their chronic disease care and hopefully prevent future flares or emergencies like this. And the other complicated element when it comes to endocrine emergencies is that they may co-occur with each other. So adrenal insufficiency can be underlining myxedema coma, can be underlining thyrotoxicosis. So being able to understand the co-occurrences is also valuable because treating just one may actually worsen the other. And again, I cannot emphasize this point enough. Being able to recognize and not miss them is invaluable because if missed, their mortality is actually very high and they're very easy to treat when they are recognized. And I like this sort of 3 delays model, these 3 circles that you're seeing for almost everything we do in critical care, which is we work off very little knowledge, very little in terms of knowing what is happening, but we start some triage and diagnosis. We start doing resuscitation. So you start your treatment even when you have a lack of information, and then you assess the response to that, and you keep doing this in an iterative, recurrent fashion to be able to come to your conclusion. And I again love, basics of internal medicine, which is clinical reasoning and what is your diagnosis? And endocrine emergencies are all about good clinical reasoning. And if you have frameworks of clinical reasoning, one of them says, is the Occam's razor, which is that you shouldn't have too many diagnoses. So plurality must never be position. So you could have many possible diagnoses, but we like to have the most parsimonious or the least, which is just one diagnosis. Or on the other hand, you have Hickham's dictum, which says a patient can have as many diagnoses as they wish for. And when it comes to endocrine emergencies, it's a lot of Hickham's dictum, where it could be more than one element happening together. And you'll see as we go through some of these frameworks how that is. I don't expect you to remember everything from all of these frameworks, but just to have an approach so that when you're thinking about these patients, you can go back to these lists and frameworks and try to approach your patient that way. And treatment of endocrine emergencies, once initiated, I find the most gratifying because patients who come very, very sick at first can often improve within a period of just a day or two. So just a review on what is our endocrine axes. So our pituitary is the mother center of all hormonal production, and as you know, and it is in the frontal part of our brain with our pineal gland. And this releases, the hypothalamus pituitary axis releases sort of the charging hormones for initiating your other hormonal glands to produce the respective hormones. So your TSH triggers your thyroid to make T3, T4, which are the active versions, ACTH for your adrenal glands, and so forth. And so one can imagine if you have any disruption along this axis, and there's many ways to get disruptions, then you'll have problems. And when we talk of nomenclature, usually a primary deficiency is related to the organ itself, while a secondary deficiency may be a central or a pituitary axis problem. And as mentioned, these can mimic many ICU syndromes that we see. So in a patient who is in shock and hypotension, adrenal insufficiency is a diagnostic imperative that we mustn't miss. Many times patients in shock may actually also have myxedema coma, or DKA, or the central cause where you have pituitary collapse, and Sheehan syndrome is the other name. And you can have, as mentioned, you can have these elements simultaneously. And so you could have sepsis from an infection, but adrenal insufficiency with that. That got manifested more. So concomitant managing is helpful. Um, Patients with stroke-like symptoms or delirium can have underlying DKA, hypoglycemia, thyroid issues, calcium issues, all types of endocrine emergencies. And high blood pressure, especially which is refractory and difficult to treat, may also be because of other endocrine underlying problems, pheochromocytomas, which are one of our favorites as med students, but much rarer in the community, but still good to think about, and hyperaldosteronism or thyroid storm again. So always keeping these in your differentials is helpful. So we'll go through a few cases. This is our first case is a 45-year-old woman who otherwise had no medical history and presented with abdominal pain, blurry vision for a few days, and these are her vitals. Additionally, she had diffuse abdominal tenderness, and these were her labs. She had a little bit of a white count. It looks like she has a bit of an acidosis. Her bicarb is low. And we did a blood gas to confirm that, and she did have an acidosis with a pH of 7.2, but her glucose was very elevated. And so for the glucose being elevated, we got a urine dipstick, which showed both glucose and ketones in her blood. I see many people in the audience. This is a pretty straightforward case. Does anyone have a sense of what the diagnosis is? That's okay. I heard people are a little shy, so oof. Oh, this is not good. That is okay. We're having some technical issues here. But this is supposed to say diabetic ketoacidosis. And this is supposed to give the full form of that. So diabetic ketoacidosis is the definition is in the name. So diabetes for diabetic ketones. So to be able to say you have DKA, you need to prove that you have ketones. And so a urine dipstick is a helpful way. And then acidosis for A is also necessary. And again, DKA is one of medicine's miracles. Before, just over 100 years ago, children and many lives were lost because of lack of insulin and recognition of this. And a very thoughtful story is that of when insulin was discovered, they started to use it in a hospital in Canada when Banting and Best discovered it, who were actually just soon out of their training when they had discovered insulin and separated it. And it was a magical scene where there were a number of children with DKA in a ward who looked comatose, who were on the brink of death because the lifespan was only anywhere from a few weeks to months if someone had diabetes. And one by one, each of the children started to awake from their comas, so to say, when they had DKA. And this is a picture of another child who received insulin. And so before the 1930s, DKA mortality was close to 100%. And we have now, over the years, reached a point where, for the most part, mortality is almost negligible. It's less than 1%. I will say that this is variable depending on where you are, and a lot of the literature from Africa has a much higher mortality, which may be related to a number of other elements, because as mentioned, DKA is a condition that may be concomitant to other medical problems, which may not have as good a prognosis, but also limits to access to insulin or other or delayed presentations to care. And the reason I presented with this patient with abdominal pain and this elevated respiratory rate. So abdominal pain, as you know, has many differentials, but we don't have a clear sense why, but many times because of the acidosis or other elements, patients may seem like they have an acute abdomen. However, it is just a manifestation of the DKA itself. Additionally, one of the presentations is this high respiratory rate. And because of acidosis, if you've had other patients who have metabolic acidosis for any reason, you'll see that in order to compensate for that acidosis, they're trying to bring their pH down. So they're trying to breathe fast to be able to uh, um, bring their pH back up from that acid state. And it may look like these patients are in respiratory distress, and sometimes these patients may mistakenly be intubated or be on BiPAP. However, this is not recommended because you want to treat the primary illness. Putting patients on BiPAP can risk increased nausea, vomiting, and then aspiration. And again, just treating the acidosis with your DKA protocol is what will really get your patients through this acute situation. And whenever you are able to diagnose someone with DKA, usually DKA doesn't happen on itself. If the patient has a known diagnosis of diabetes, oftentimes there may be an adherence or access issue to their insulin. However, regardless, throughout your cycle of evaluating your patient, it's imperative to look for what triggered it. Was it an infection? Is there an MI? Were they having some substance use which increased their metabolic needs? Do they have some medications which also could put their body at increased stress? So a number of triggers can be possible, and not treating the trigger simultaneously is invaluable. I've put this picture of mucormycosis here because one of the first patients as a medical student that I saw was like this little kid in picture E with mucormycosis, and prolonged hyperglycemia and diabetes and not looking for triggers can lead to this, which is almost fatal, and needs early surgical debridement along with treating the medical condition. And it is a very sad situation to be in. But again, early diagnosis, early treatment is invaluable. And I don't expect for you to be able to read this, but to just say that there are many protocols for DKA, and the way to make DKA management the simplest is to just blindly follow a protocol. And for that, one needs to very closely monitor the patient as they're on an insulin drip or receiving insulin, but with keeping an eye on very simple metrics that will monitor and titrate to a good equilibrium. So protocolizing everything, and so looking for your underlying trigger. But the main treatment is very simple. You need fluids, you need insulin, and both of these can alter your electrolytes, so you keep a close eye on your electrolytes. But some controversy exists in various elements of this. So when it comes to fluid, what fluid should we use? The options are varied. The main conundrum is whether to use normal saline or balanced crystalloids, which includes things like Ringer's lactate. And overall, there's no clear evidence decision as to which is better. I would say in my practice and based on a number of trials, the degree of acidosis where you can get an additional iatrogenic acidosis from normal saline is a little more. So sometimes the ability to resolve can take a bit longer with normal saline. Additionally, there was a big trial on fluids in a mixed population, not just DKA, where they assessed for the balance of these and found that patients with normal saline may have an increased risk of acute kidney injury, and these patients are fluid deficit, so that risk can be higher. So in my practice, I tend to lean towards Ringer's lactate. There have also been meta-analyses of all of the recent fluid trials where they stratified for DKA, and this is a nice discussion where they talk about that. And in those patients who received LR, the time to resolution of DKA was faster, and so that's another reason why I prefer it. But regardless, whatever fluid of these two you may have access to is helpful. And then electrolyte repletion cannot be minimized. So going back to medical school pathophysiology, when you have acidosis, your potassium goes out of the cells. And patients who are in DKA are also having osmotic diuresis. They're also very volume deficit. So overall, one can imagine that the total body potassium is actually quite low in these patients. However, insulin, when we give it, does a couple of things. So insulin, when is given, activates your sodium potassium ATPase pump and drives potassium into the cell. And along with that, actually, phosphorus also goes into the cell. And because of this, one of our main worries is that a patient who has DKA, even if their potassium is, say, normal, 3.5 on initiation of the DKA protocol, when you give insulin, that potassium is going to go even further down. And that risks your patients getting arrhythmias and cardiac arrest and other issues. So within your protocols, there will be very clear guidance on how frequently and how much potassium to give. But also, if you reach a point where your potassium is low, while we want to treat the insulin deficiency with DK, the goal is to not do it at the risk of your electrolytes. So we may have situations where you have to absolutely stop the insulin drip just to work on good electrolyte repletion and then reinitiate your drip when it's safe. Another element which I find very fascinating and relates a lot to how our body functions, especially in starvation states, is how our phosphorus levels can be really low. And we may not always think about this electrolyte when we're thinking about DKA. However, in refeeding syndrome, your insulin does the same thing. Your body receives insulin and drives phosphorus into your cell, and then your cells have been starved for a while, so suddenly use up all of that phosphorus to make ATP. And if your phosphorus levels are low, when you start insulin, these can be further driven down. And so you can get arrhythmias again, rhabdomyolysis, and respiratory failure, cardiac failure. So having enough ATP stores and phosphorus stores is also important as a part of your electrolyte repletion. And there's a couple of other electrolyte derangements that you see. Hyperglycemia in itself can lead to a pseudo hyponatremia picture, but it could be a true sodium deficiency as well. And so it's important to keep a close eye on that. Especially in children, they are at high risk of cerebral edema. And so just as you approach severe hyponatremia or other hyponatremia states, it'll be important to keep an eye on the sodiums and go slowly up on that. Magnesium deficiency is also seen. And as we discussed, the acidosis can lead to hyperventilation, which is not from a respiratory failure cause. And then your insulin protocol, there are many protocols, and following one is helpful for knowing what rate to go up or down and bring the glucoses down also in a slow and steady fashion. And when to end is really as you're checking your anion gap. Once that gap is closed, so sometimes patients come in with a very low bicarbonate, and their anion gap may be anywhere from 30 to higher or lower. And so waiting till it's closed or less than at least 12 for a few checks, at least 2 checks is our protocol, is helpful. And you will actually see that the bicarbonate may still run low for a while, and that's because the beta hydroxybutyrate and the keto acids are still in the body, but that the patient is still in a safe zone to be able to be resolved from their DK. But the most tenuous period for these patients is really when we are transitioning from their drip to a subcutaneous formulation and bridging. And so keeping a very close eye on these patients then is important. And many times what we'll do is we'll give the subcutaneous insulin, but continue to run the drip for 1 or 2 hours while we're waiting for the subcutaneous insulin to take effect. And warranted, there are protocols out there for mild DK, which can also use subcutaneous insulin alone. So making sure you're following a steady protocol is very helpful for you and your nursing staff for what to do and how to approach this. So DK is probably one of the most common endocrine emergencies you'll face, and invaluable to know the nuances about. All right, our next case is a patient who we know has diabetes and presented with a seizure. They had altered mental status, that poor airway protection, so you intubated them. But part of your evaluation for seizures is to see, do they have hypoglycemia? And they did. So we gave them dextrose and they got better. And so, as you are aware, hypoglycemia has many manifestations, including seizures. And the first thing to check for anyone with any altered mental status is to just get a finger stick and check for their glucose. However, hypoglycemia, if it's recurrent and not responding the way you expect, it can be due to other causes. Many of your patients in the ICU you may already have experienced due to acute illness and increased demands, especially in liver failure, where your liver is unable to make glucose, can lead to hypoglycemia. But intoxications, iatrogenic or patient-driven, can cause hypoglycemia. Sulfonylureas, if patients are on them, can do it. And then speaking of concomitant endocrine emergencies, adrenal insufficiency is a very common issue that can lead to hypoglycemia. However, if despite treating and it remains persistent and ongoing workup is unclear, one may even think of an insulinoma, which are often very challenging to diagnose, but also then ensure adequate treatment for. So knowing the cause helps overall with your treatment as you're temporizing your patients. So speaking of glucose in the ICU in general, and this is for all patients, regardless of what their underlying diagnosis is invaluable to keep a close eye on what your glucose goals should be. There was a landmark trial over a few decades ago called the NICE Sugar Study that looked at, it was a randomized control trial with 3,000 patients in each arm, where they looked at an intensive group. So oftentimes, theoretically, we may think a lower glucose in a tight control may be better versus a more broad conventional control of anywhere less than 180 milligrams per deciliter. And when they followed these patients, overall they were equivalent in both arms. However, mortality was higher in the intensive group, and severe hypoglycemic events were also higher in the intensive group. So for all practical purposes, we keep our goal glucoses in anywhere from 140 to 180 for patients who are critically ill for any reason of critical illness, and to avoid episodes of hypoglycemia and increased risk of mortality. Lovely. So coming to our next case, we have a lady who is 66, has a history of diabetes, but also a history of hypothyroidism, hypertension, who presents with altered mental status. She was found to have a UTI, and so they were treating her. But despite this, her delirium continued. She was then called by you in the ICU because her blood pressure dropped. She was in shock with a low blood pressure, a low heart rate, some hypothermia, and on exam was found to have these changes in the A and B picture. And you also were a very astute assessor and did a neurological assessment and found that her deep tendon reflexes were delayed or took a slow time. In her labs, she had hyponatremia. She was hypercarbic on her gas, and she had a low blood glucose, but the rest of her labs were normal. So this is a very classic from all elements presentation of what is mixed edema coma. I will say that not all patients will present with overt, perfect, great, Mahalet. Um, uh, Not all patients will be able to present with such an overt and obvious clinical presentation. We had a patient in our ICU just last week who has been in and out of the ICU with question for sepsis and had many of these manifestations like hypothermia, bradycardia, and even the non-pitting edema. But many times it's very subtle and you may not see all of the classic findings. But knowing if a patient has had a history of hypothyroidism can be helpful in trying to lean your diagnosis in one way or the other. But the element which I actually find in some ways encouraging is that this is a clinical diagnosis. So unfortunately, a lot of these labs, if you are to send them, can take a while to come back, and that may delay diagnosis. But in especially thyroid emergencies, labs are often not helpful, and having a clinical gestalt an approach and empirically treating is the most helpful. So mixed edema coma can occur in someone who has hypothyroidism already and may have a new stressor, which causes any type of end organ damage. And so the word coma is a bit of a misnomer because you may not always have coma, just any altered mental status is also possible. These patients, because as you see, there's a lot of neck tissue. Sometimes patients can have macroglossia or a big tongue, and your respiratory drive is reduced. These patients are at high risk of respiratory failure. And hence she also had hypercarbia in this case. But what was most humbling to me was with the case we recently had was that the mortality for patients, if this diagnosis is missed, is almost 50%. So half of your patients could die just from not noticing that they may need some extra thyroxine. And as with diabetes, DKA, where we looked for a trigger, even with mixed edema coma, it's important to look for a trigger, what caused that increased stress, so that we can treat that. And in this case, it looks like it was probably the UTI. So there are many other triggers. I use the framework IIMM, which is infection, inflammation, metabolic, malignant, and that can help you cover a lot of elements, and many drugs can also trigger. So any acute illness can be an underlying trigger for mixed edema coma as well. And so, as I mentioned, lab testing may or may not be helpful. As you would imagine, the TSH in hypothyroidism would be high, and the free T4, or the active version of thyroid, would be low in primary. However, in secondary, which is pituitary related, you may not see either of these changes, and they may be all normal. So lab testing may not always be helpful, but if you are thinking of it, it's good to also send these and a baseline cortisol level. And why? Because concomitant, many of the endocrine emergencies can be associated with autoimmune conditions and have concomitant adrenal crisis as well, which could be triggered if you give the thyroid hormone. But another reason to not send or think too much about thyroid labs in the ICU is this concept of the sick euthyroid syndrome. If we go back to our thyroid pathophysiology, our pituitary makes TSH, which triggers the thyroid, which then synthesizes T4, which is the pre-drug version of active hormone. And this in the periphery is then converted to T3, which is the active hormone which acts on our various organs. However, there's this little blue element, RT3, which is called reverse T3, which is also synthesized in a very small amount at times. However, when we are in a situation of stress, this dotted line on the top, our reverse T3 levels or conversion of T4 to reverse T3 goes up. And reverse T3 is not an active version of thyroid. So when we're in a stress state, our body is in fight or flight mode and is not converting the amount of thyroid that we need appropriately. And so our lab findings may be disarrayed and not be reflective of the patient's true baseline thyroid status in an acute situation. So many times, if you do send thyroid studies while you're in the ICU, they may be off, but may not mean a lot, and should be repeated once the patient is better, out of the ICU, in the outpatient setting, and recovered, potentially after anywhere from 6 to 8 weeks. So this is an important concept because many times we'll send them out of theoretical interest, but their interpretation is more challenging, and decisions for thyroid emergencies especially should be made on a clinical basis and how sick the patient is looking, and less so on the lab findings themselves. And so the treatment for mixed edema coma is, as mentioned, not to delay, give treatment empirically. And because of the risk for concomitant adrenal insufficiency, empirically give stress dose steroids, which includes hydrocortisone. And there's a lot of debate in the literature of what type of replacement hormone for mixed edema coma should we give. Should we give T4, which is the pre-drug version, or T3, which is the active drug version? And there's no clear RCTs to help us discern this. However, an approach that most people use is a bit of a combination, if you are able to, with T4, which is levothyroxine at a very high dose, 200 to 400 micrograms IV, followed by 50 to 100 after that, till the patient is able to be awake and take PO. And the reason for this is to build the stores and reserves. However, you still have to convert this from T4 to T3 in the periphery. And if patients are very sick, that may be a slower process. Hence, some individuals also give a small dose of T3 or leothyronine to help with the active need. However, to be careful with T3 use, especially in elderly patients who may be more at risk for arrhythmias, where some studies have found an increased mortality. And again, looking for the treating with for the trigger, and providing supportive care for all other medical issues. All right, so we've got through 3 cases and saved that many lives. Coming to our 4th case, this should also be a straightforward one for you all. So this is a 34-year-old lady who recently had surgery for appendicitis. And during the surgery, actually had an issue where she started to become tachycardic, went into atrial fibrillation, and had a fever. And post the surgery remained altered. Of note, there was some prior history of weight loss, and on exam, you notice her eyes look like this, which is proptosis. And then you did a further thorough assessment and found that she had a large thyroid gland and had brisker reflexes on your neuro assessment. So this is a pretty classic version of presentation of thyroid storm. Also a clinical diagnosis. And I would say this is probably one of the hardest to diagnose because, again, not every patient will have the features of Graves' disease, like in this case. Sometimes you could have thyroidoxicosis without, for other reasons, and not Graves' disease with these manifestations. And there is this scoring system called the Burke-Work-Tofsky scale. But if you look at it, all of the elements are present in any patient that you may have in the ICU with sepsis, with heart failure, with any other acute illness. And so it's a very non-specific scale. And so again, knowing if the patient had any prior thyroid history or having a very low suspicion is very important because if missed, has again a very high mortality for these patients. It's especially challenging to diagnose in the elderly because patients may overall feel fine and their only manifestation may be atrial fibrillation and heart failure. So thyroid storm is easy to miss. Also, like our other endocrine diagnoses, can have many events which trigger it. And so in our case, it was a surgery that triggered it. And treatment is also multi-pronged. So you're treating by trying to decrease the active thyroid hormone, but also treating the underlying trigger and providing supportive care and monitoring. In terms of in terms of the hormone synthesis, so as you saw with our other case, your T4 is released from the thyroid gland and converted to T3. And propylthiouracil is a good agent which delays some of that conversion, while methimazole also helps overall block your thyroid synthesis. However, this is just helping with the new synthesis for the existing hormone, which is in your body. We use iodine, which, as you know, if you don't have iodine, you can get a goiter. And so, too much iodine can actually help block your thyroid gland. And so, these are the doses of either Lugol solution iodine or potassium iodide, 8 drops. However, um, what is important here to note is to make sure the order in which we give it is correct. So if you were to give iodine first, your thyroid gland is going to take that iodine and make more thyroid hormone and can actually worsen and exacerbate your thyroid storm situation. So the goal is to first give PTO or methimazole to first stop the synthesis at the gland, and then subsequently you may give iodine. And so protocols will actually have you do one of them first and then very soon after give iodine so that that is not missed. Because if you do the reverse, we actually end up in a situation where you can cause more problems. All right, so moving away from the thyroid, we have our last case. This is a 45-year-old lady who unfortunately had lupus, was on prednisone chronically, mostly joint-related symptoms, and presents now with a fever, nausea, vomiting, diarrhea, and a low blood pressure in shock. Her labs were otherwise fairly unremarkable. And so her diagnosis most likely is adrenal crisis. However, adrenal crisis from what? We still have to look for an underlying trigger. Does she have a new infection? Does she have another medication-related complication or not? And just as we've been reviewing in terms of whether this is primary or secondary, so generally primary adrenal crisis patients tend to be a lot sicker. They may have something we call salt, that is called salt craving. They may have more mineralocorticoid deficiency, which leads to more electrolyte deficiency. So the classic teaching is a low sodium and a high potassium, which doesn't seem to be the case in our patient. However, in secondary adrenal insufficiency, this can happen classically in a patient like her who's been on chronic steroids and then may either suddenly withdraw from the steroids or have a new trigger which causes her to need more stress hormone, but her adrenals are not able to cope because she has been receiving exogenous steroids for so long that her adrenals have become insufficient. And so anywhere from over 20 milligrams of prednisone for just 3 weeks can cause you to become adrenally insufficient. and put you at risk for an adrenal crisis. So to be very careful with providing these recommendations for patients on chronic steroids, to watch out for stress states or sick days in terms of what to do if they are having a new stressor on top of being on chronic steroids. So the treatment diagnosis, one can do an ACTH stimulation test or check a random cortisol. Of note, if you give hydrocortisone for treatment, it can make your cortisol levels off, because it is basically cortisol. And so if you do want to send these tests, you should do it prior to treatment. But as you can imagine, a patient in shock doesn't have time for prior to treatment. So many times, and most of the time in the ICU setting, we have to empirically treat. So you'll give a stress dose steroid of hydrocortisone 50q6, and then closely monitor or treat the underlying trigger. And as the patient improves, slowly taper them. Of note, dexamethasone, which we've used a lot, especially during COVID and other situations, does not have the mineralocorticoid activity, which is very important, especially if you're in shock. And so to avoid using that specific steroid as a replacement, but others are okay. And along with all supportive care for electrolyte and volume repletion as well. Right. And so just to take a side note for, again, general critical care, regardless of the underlying cause, many of our critically ill patients can have this concern called CIRSE, or corticosteroid, critical illness-related corticosteroid insufficiency. And this is often seen in patients who may have chronic ICU needs, or one medication we often use for intubation, etomidate, can lead to adrenal insufficiency. Other drugs can also contribute. And CIRSE is basically adrenal insufficiency, and also needs to be treated like an adrenal insufficiency, but is something to keep an eye out for in your critically ill patients, because they're in an increased stress state, and their adrenal glands may not be able to cope with the degree of stress hormone that is needed in those stress states. And so we may need to give additional supplementation for patients. And these are some lovely guidelines which go over how to assess for them and how to treat them as well. And so we couldn't cover all of our endocrine organs, but I just wanted to leave you with a few additional thoughts for different endocrine emergencies. So we talked about CIRSE. Sheehan syndrome is a eponym for basically panhypopituitarism. And these patients also, one imagines that all of your hormonal axes are disarrayed. But the most concerning emergent issue is if these patients also go into adrenal crisis. And the classic case may be someone who had hemorrhage, especially postpartum hemorrhage or around pregnancy, and then they're not able to breastfeed and they're in shock. These situations may trigger this concern. And again, treatment would be stress dose steroids. Hypertensive crises can often have an underlying hormonal or endocrine problem. And so patients to think about sending an endocrine evaluation for are those who may be young with hypertension, refractory hypertension, so that if they're on more than 3 drugs and they're still hypertensive, or if they've had some imaging at some point of their abdomen and you found that they had an adrenal lesion associated with hypertension. And why it's important to send the workup early is that you may have a patient on, say, a nicardipine or a labetalol or a hypertensive emergency protocol drip. But when you send the studies, they often take a very long time to return, especially if you're thinking things like pheochromocytoma, where you send urine metanephrines and other diagnostic tests. So sending an early evaluation for thyroid, calcium, other elements also is very helpful in their overall management. If you are strongly thinking pheochromocytoma, to avoid beta blockade alone, because it can lead to unopposed alpha activity and actually worsen your hypertensive crisis. A classic presentation for hypercalcemia is the sort of mnemonic of bones, groans, stones, moans. And this is basically patients who may be confused and having a lot of pain and have high calciums. And the risk with hypercalcemia is also hypertension, but arrhythmias and sudden cardiac death. And so treatment is geared at trying to lower them by giving IV fluids, calcitonin, and bisphosphonates. However, if you have kidney disease, to consider denosumab, which is a little challenging to get in the acute setting. And then low sodiums or severe hyponatremia also has a lot of endocrine evaluation. And so especially if you have someone who's euvolemic and you're thinking SIADH, it could actually just be hypothyroidism or adrenal insufficiency. And so sending a cortisol and a TSH and assessing for those is also important. And if you have a patient who has a high sodium, on the other hand, and despite having a high sodium is still making a lot of urine, often more than 3 liters a day, then diabetes insipidus, which is as you imagine, from your hypothalamus to your pituitary, that tract in the posterior system can be disarrayed. And so giving vasopressin, which is the hormone that helps us retain water, and seeing how you respond is helpful for the assessment of that, to determine, is this from a kidney cause? If you give DDAVP and it does not improve, then it's probably a kidney cause. While if you give it and it improves, it's probably a central cause, because you're not making the hormone, but your kidneys are able to hold on to the water once you give DDAVP. So that was a whirlwind, and a lot of different hormones, a lot of different presentations, but the key principles are know your illness scripts. So while these were very classic presentations, you may have subtler versions of these with all of your ICU syndromes, whether it's shock or hypertensive emergency or delirium. And so thinking about and having a high index of suspicion for these endocrine emergencies is invaluable as you're investigating and managing your patients, but making sure you're not prematurely closing and only thinking about the endocrine emergency like DKA, but also treating underlying triggers. And once you're able to get them through their acute state, these are eventually chronic conditions and need good supportive care to prevent flares that bring them to your ICUs. So ensuring that they have a good outpatient regimen once you've gotten them all fixed and better. All right. And thank you all for, listening and being here. And I love the turnout. And open to any questions.